Hello, everybody. I'm Dr. Gowri J. Murthy, and today I'm going to talk about a few pitfalls in the interpretation of OCT in glaucoma. OCT, as we all know, is a valuable tool in the diagnosis and monitoring of disc damage in glaucoma. It measures the retinal nerve fiber layer around the optic disc and also detects the macular and ganglion cell layer thickness. And these two parameters are very helpful in the diagnosis and monitoring of glaucoma. However, as in the use of any technology, the knowledge and strengths and limitations of the technique and recognition of artifacts and errors in image acquisition and accurate interpretation is very important. In this discussion, I shall show you various imaging artifacts in ONH and RNFL imaging, which could influence the interpretation. I will use the examples from the spectral domain OCT, that is the Cirrus HD OCT, and the Spectralis from the Heidelberg Engineering Company. The principles of identification of artifacts are, however, similar across all the available platforms. I have no financial interests or otherwise in this presentation. Also, the errors in OCT images of the optic nerve head and RNFL can be classified as acquisition or operator related, artifacts due to pathology or anatomical features of the eye, and artifacts due to machine related factors. As we all know, optic disc size is very variable. Imaging in a large optic nerve head is likely to introduce false positives in the ONH analysis. And on the other hand, imaging in a small optic nerve head can miss small defects and lead to false negatives in the analysis of the minimum rim width. Therefore, one should be mindful of the optic nerve size when one is interpreting the OCT. Signal strength or scan quality affects the OCT performance even within the manufacturer recommended limits. The effect is greater on the retinal nerve fiber layer than on the ONH and the GCC. Cataract is a major culprit that can lead to a low signal strength. Dry eye and ocular surface abnormalities can also cause poor image quality. There are certain operator-related artifacts which can be present in the OCT image. One is during a blink. If a patient blinks during the acquisition of the scans, a portion of the data in the ONH cube is missing. This is indicated by a dark or black band on the reflectance image on the printout. This can lead to errors in the RNFL thickness estimation, and such scans should be discarded. These errors can be minimized with careful training of the operators. During the acquisition of the scans, if part of the RNFL image is truncated or cut off due to inaccurate optimization of the scans, this can happen in staphylomas in myopes as well. This leads to errors in the RNFL estimation. Such scans are also to be discarded. This is another example of absent data due to blinking, and such scans should be discarded. Certain times micro eye movements occur, and this results in an abrupt horizontal cutoff with misaligned vessels on the scan. Results from such scans also should be viewed with caution. Sometimes eye movements during scan acquisition can result in shadow images of the ONH and blood vessels. In these cases also, the analysis will be inaccurate and the scan should be discarded. Let us look at certain patient-specific or pathology-specific artifacts. Here you can see there is a PVD which has occurred. The vase ring interferes with the imaging of the ONH, BMO, and the markings which are seen in the OCT. The vase ring causes the underlying OCT image to be of poor quality. The determination of the disc border is made usually by the automated marking of the Brooks membrane opening or the BMO in the Spectralis machine. The minimum rim width or MRW is the least perpendicular drawn to the ILM from the BMO. Therefore, if the BMO is not accurately detected, this introduces artifacts and errors in the analysis and the ability to distinguish between a normal and a glaucomatous disc. If you can see this image, the BMO, which is indicated by the small red dots in this picture, has been detected inaccurately. You can see this comes into the substance of the optic nerve head here. And as a result, you can see that the upper two sectors have been marked as borderline. So one can correct the BMO marking manually by looking at the images when we go to the image module on the Spectralis machine. And once we correct the BMO to accurately represent the Bruch's membrane opening, you can see that the borderline area has reverted back to green or now normal. So one should always check the BMO correctness before going on to the interpretation. Centration is another important aspect. Spectralis OCT scans are considered decenter when the center of the optic nerve head is more than approximately 10% of the center of the peripapillary circular scan. As you can see in this example, this scan is grossly decentered, and these errors cannot be taken, these values cannot be taken at face value. Once it's properly centered, one may find that the borderline and abnormal markings do go away. Shadowing and missing data in the ONH scan could be due to vitreous opacities. Here you can see a small vitreous opacity here, and that has resulted in shadowing of the OCT scan, and therefore you have missing data here. Therefore, there is no color which is denoted over here, and the graph just dips down, and this indicates that in this area the data is not available for the machine to interpret. Blood vessels can cause apparent increase in thickness and can also cause back shadowing. Here you can see a large blood vessel which is causing back shadowing. And this can result in wrong marking of the minimum rim width. Again, you see a blood vessel, and this is causing an artifactual increase in the RNFL thickness. So this is again something that one needs to look for. Other findings like myelinated nerve fibers can also cause back shadowing. You can appreciate in the scan that there is a segment of myelinated nerve fibers over here, and the corresponding scan over here, you can see that there is shadowing of all the structures posterior to the myelinated nerve fiber layer. And myelinated nerve fiber layers can also cause an apparent increase in the retinal nerve fiber layer thickness. If you can see in the left eye here, the circle cuts the myelinated nerve fiber layer area. It is going around above the myelinated nerve fiber layer area. So wherever there is the myelination, you can see that the RNFL is artifactually thickened. So myelinated nerve fibers can cause apparent increase in RNFL thickness, and this is something that one should keep in mind. As I earlier said, vitreous opacities can interfere, and you can see in this picture that this vitreous opacity can be overcome by changing the circle to the larger circle, where you take the circle away from the area of the vitreous opacity, and this can give you a meaningful scan which can be interpreted. Traction on the retina due to PVD occurring can also cause apparent increase in the thickness. You can see here that the traction around the disc here, peripapillary traction, is causing a artifactual thickening of the RNFL. Here again, you have a traction which is causing an artifactual thickening of the RNFL. In such scans, instead of taking the central, the innermost circle, one can take the outermost circle where the traction is not present, and this scan will be more useful for diagnosis and follow-up when compared to the previous one. Segmentation is the process by which the OCT software identifies the borders of the RNFL so that it can report its thickness. These segmentation algorithms allow identification of both the anterior and posterior limits of the RNFL, and there can be errors in the segmentation which can cause errors in the measurement of the retinal nerve fiber layer thickness. So let's look at an example here. You can see this red line is the anterior border, you can see that it has been inaccurately segmented. So there is some amount of RNFL which has been missed, and the segmentation goes into the RNFL area. So these kind of errors can lead to erroneous results. This borderline here is due to the erroneous segmentation. This can be evident even on a printout like this. One should look at this portion of the printout where you will get the segmentation details. The best way to look at these segmentation details is to go back to the machine or use your interface, user interface, and link to the images directly on the OCT machine and check the segmentation online. This is an example of incorrect posterior segmentation. So posterior border of the RNFL is marked in blue or bluish green. And you can see in this scan that it is coming inside the RNFL area itself. So this kind of inaccurate segmentation can also lead to falsely abnormal results. So again, this can be detected on the printout, but I would strongly recommend one to go back to the machine to check the segmentation. So you can see in this example that in the middle here, the red and green lines are coincident. That means that the segmentation is totally inaccurate over here. And that is the reason why the Tisnet graph dips into the red and beyond here. This is an example of a patient with very high myopia with peripapillary atrophy. Such eyes are very, very difficult to image and are beset with large amount of errors. And you can see here that the peripapillary atrophy confuses the algorithm and the segmentation is not at all accurate. Again, tilted discs with peripapillary atrophy can also lead to segmentation errors. If there is a peripapillary atrophy and the RNFL segmentation is inaccurate, sometimes increasing the diameter of the circle can allow you a better image, which can be used for diagnosis and further follow-up, as is illustrated in these three images. Extreme examples of pathological myopia where there is a tilted disc and low scan quality, segmentation goes haywire, and such scans are not at all useful and should be immediately discarded. Not every time the OCT tells you that everything is green means that the patient is normal. Sometimes focal defects in the RNFL, like you can see over here, there is a focal RNFL defect which is going from the superior temporal aspect of the disc, is totally missed by the sector and the quadrant maps. One should pay close attention to the Tisnet graph. If you can see on the Tisnet graph, there is a small dip here into the red zone, and the red free image shows the RNFL defect very clearly. And when you look at the GCL thickness map, then you can see that there is a break in the hot colors, the ring which is supposed to indicate the macular thickness. There is a break here, which means that this area, the thickness is less. So all these small things give you a clue that there is actually an abnormality, and this green here is not what it looks like. This is another example of the green disease. If you cursorily look at this OCT, everything looks normal, green, and the GCIPL also looks normal. But when you look at the red-free image, you can see slit-like RNFL defects here, this one, and a very large one, in fact, over here. And if you closely look at the Tisnet graph, if you take the second circle, you can see that actually the Tisnet graph dips into the red, where the nerve fiber layer is present. So you should go back to the machine, check the actual images, check the segmentation, and check the Tisnet graph in a magnified way. And then only one can decide whether this scan is actually normal or abnormal. In summary, one should look for segmentation errors. One should examine the Tisnet RNFL plot to make note of whether the location of the peaks correspond to the peaks from the normative database. One should correlate the GCIPL thickness map with the Tisnet graph. Look for presence of tilted discs and peripapillary atrophy. and be aware of the artifacts that are possible. And we also should recognize that ocular disease can create errors in segmentation, and we should check for that. And most importantly, correlate with clinical examination of the disc and retina and the visual fields. In conclusion, imaging devices potentially assist the clinician to diagnose and monitor progression. However, management decisions should not be based solely on the output of an imaging device. One should place less weight on a test if there are any concerns about the device's performance in a particular patient. We should ensure that technicians acquiring the images are appropriately trained. We should reject images taken at extremes of refractive error. Also reject images with poor quality or place less weight on the information provided by these images when synthesizing all the relevant data. Remember, we need to think. The machine doesn't have a brain, so we need to use ours. Thank you.